So next, we have a relatively new group of sites, a large team represented by this table over here and these two lovely gentlemen. And I'm going to let you guys introduce yourselves. You've got this.
Hi, everyone. Good afternoon. My name is Adam Nicholson. I'm a peds emergency medicine physician at Helen DeVos Children's Hospital in Grand Rapids and the clinical champion for Helen DeVos.
My name is Tom Chogish. I'm also an ECS physician. I work at Helen DeVos as well, and I'm a pediatric regional clinical advisor for Spectrum.
So we're going to shift focus and actually talk about head injury. So reduction of our CT utilization in children with minor traumatic head injury. I think our experience is a little bit unique in what we're going to be talking about, because as a pediatrics, when we started our participation in MEDIC in 2019, we were already seeing that we were meeting the organizational goals. But as a group, we're employed by emergency care specialists, which actually staffs many sites throughout West and North Michigan. And we saw an opportunity to leverage the success we were seeing at the Children's Hospital and translate that knowledge to our providers throughout the region. So a few objectives that Tom and I want to address today are help us to describe best practices in the management of minor traumatic head injury, discuss our quality improvement methods for spreading evidence-based best practices, talk about our improvement trends, and then discuss our collaboration techniques that we've used between our clinicians, our program leads, and our abstractors. So a little bit about Helen DeVos Children's Hospital. If you're not familiar with our site, we're a 234-bed freestanding children's hospital located in Grand Rapids. Our current building opened in 2011, and prior to that, there was a children's hospital located within the adult hospital. And we're part of what is now BHSH healthcare system. My understanding is the new name is probably coming out soon in the next couple of weeks, so another name to update soon. We are a level 1 pediatric trauma center. Just as Chelsea, she abstracts about 300 head injury cases per month, just to get a sense of our volume of head injury cases. But we have 56,000 ED visits per year. Our staffing model, we have 20 core attendings. 11 of us are peds trained either in peds emergency medicine or dual board trained in peds and emergency medicine. We have an accredited Penn Fellowship program and multiple residency programs rotate through our hospital. And then, as I stated, Helen DeVos has actually been a MEDIC member since 2019. So I'd say our success that we've seen at Helen DeVos predates our participation in MEDIC. Helen DeVos was actually one of the original data collection sites for the PCARN study that was published in 2010. So work had been underway for many years to get better adherence to the low risk algorithm and implementation of using PCARN as the head imaging guidelines. So even before we started this work, we had Epic tools to help us assist us in decision making. We had a quality dashboard built, which had already included head CT as a measure. That was discussed at monthly department meetings. As I stated, with having all of our residency programs, PCARN is a typical subject of focus when we talk with our residents and fellows as they're coming through the department. So a regular part of conversation every time that we see children with head injuries. And I think overall, as I noted, we have a large number of peds subspecialty trained physicians, so there's just greater familiarity and comfort in, I think, identifying those patients and then having those conversations with families about why we don't necessarily think a head CT is necessary, because I think that's part of the critical aspect of not doing a CT is having that comfort and dialogue and kind of your go-to toolkit to use with families who are a little on the edge about whether they want a CT or not. So you'll see our performance since participation in MEDIC. Largely, we have been meeting collaborative wide goal month to month. You'll see in 2020, we actually had a blip, and I think that actually is a consequence of having a lower denominator of patients during those few months. So a lot of the struggles that we see in some of the other sites where you see so few patients, so that 1 or 2 CTs that you do order bump you up, we fell victim to that, I think, during that period when we saw our volumes drastically decline over that time period as well. But largely, we've been able to sustain our improvement, and really year to year, our goal really is to sustain being at the level that we are while still trying to drive improvement. So I'm gonna hand it off to Tom. So he's gonna talk about how we're using our experience in the PDD to kind of spread our knowledge.
To start, I think we'd be remiss if we didn't recognize we had a really good example to follow, sort of birthed in patient experience and quality. Adam and folks at the Children's Hospital set a really good example. Stealing, I think, from Keith's presentation, how our group is sort of constructed and its fingers reaching different places gave us sort of an opportunity. The evidence was already sort of there and didn't necessarily change, but then the impact that we could have was perhaps a little different. So we're looking at the same measures, same targets, same collaborative wide targets, but sort of trying to disseminate that info to different people. And in the next couple of slides, you'll see those sort of tendrils go throughout West Michigan and hopefully get a sense of the impact we can have from there. So Emergency Care Specialists is a physician-owned, physician-led group. It's headquartered in Grand Rapids, but we staff 16 different Michigan facilities, mostly through West Michigan and then Owasso to the east there. Our group sees just over 450,000 patients annually as far as just our providers. And ECS participates in MEDIC as an independent provider group. Here again, I hope we can see sort of this bleeding of information or disseminating it through numerous different quality venues and a quality spot in several different meeting points. We can take and engage physician leaders intentionally to help us sort of spread best practice throughout the group and then to different providers and different facilities throughout the state. We have a pediatric head injury work group that meets quarterly, and actually a nice part of this is we take people from ECS. We include emergency medical directors at Helen DeVos. We also include people from the Helen DeVos team, so that sort of collaboration continues. Our regional medical director meetings meet on a monthly cadence, and there's both, I'm lucky enough to have a spot there to talk about quality, but there's also the ability to sort of engage those leaders of different sites and give both updates in real time, review trends, or sort of include more of a focus when it's needed, depending on where data is currently. Department meetings, and then the slide following this sort of bleed together a bit. Department meetings, again, happen monthly. You have sort of a different group of people that attend those, so your audience is slightly different. And again, you can sort of get a sense for this information or initiative sort of leaving just a small core group of people. We're able then, through department meetings, but then going to individual pod meetings, the cadence of those is a little different, but each site meets monthly or bi-monthly, and again, are kind enough to give us a platform to sort of go over this information. Our feedback both to sites is site-specific, but as individuals, we can drill down to the individual level, especially if we have outliers, like I think was touched on with a previous presentation. So if we, for better or worse, we can actually talk to those providers and try to identify what, if anything, was a barrier to sort of falling outside of best practice. As far as our data goes, we have several tiers. So SharePoint, on our SharePoint site, I should say, there's data that's available and unblinded whenever. So on your couch at 2 a.m. or in a much more formal setting, we have quality as a part of our our scorecard system in our group. In addition, we have the ability to sort of give individualized feedback at different points in time. Our outreach education, as we sort of leave this slide, again, we see that information, that evidence-based best practice leaving our group and again, sort of fanning out a bit. So we have one urgent care site that our providers staff, but also we have, right now it's quarterly, we have meetings with our urgent care providers, most of them Spectrum Health urgent cares, where they tell us sort of, can you focus on X, or can you suggest something, or what are you seeing in the emergency department that maybe we could close a gap as far as referrals to you from us. So that again happens sort of quarterly. At the user level, we have weekly updates that we send out to all of our per diem employees, partners, and include a definite quality focus weekly, at times a specific type of medic, at times a medic update. We, to the right of your screen here, the PCARN pocket cards were initially created from the PCARN folks themselves, and in communication with them, we sort of got some permission to adapt these. specifically adding some information at the bottom of them that you see there for intermediate risk head injury. There was a previous slide, I think, as we were going through initiatives that said what qualifies as intermediate risk. And I think some of our providers use that as a quicker out to scan someone. So focusing a little bit differently on, well, what is your risk if you have a single factor that qualifies you as intermediate risk has seemed to help. Adam mentioned DeVos had, and now all of our sites have as standard through an Epic upgrade, a PCARN tool that helps with scoring and therefore documentation. And then now we're at about quarterly for skills days, which we involve APPs and physicians. Anyone in our group is welcome. At each of those skills or simulation days, we have a focus or a medic table or a quality table that we can go over. Here's our data. I'm going to talk about the bottom of the slide really briefly first, because you see our denominator and our numerators at the bottom. So as I go through, this is excluding Helen DeVos data, because as Adam mentioned, it would be much, much bigger numbers. So these are the other sites excluding Helen DeVos. So when we started, the collaborative-wide goal is less than or equal to 18% for intermediate use head CT. The first 3 months of data extraction, we were averaging about 30%. If you looked at the first 6 months of 2021, we were around 24%, and then looking from from November 21 to June 22, we were more like 16%, showing sort of a significant improvement. The next slide, you'll see a very similar and probably more familiar appearing graph with that same slope line that sort of shows the ebbs and flows, but a consistent overall improvement or shift toward the green. I know this is somewhat hard to see, but the thing I want to point out here is every dot with a tag here with the wording above it is a site that's sort of unblinded to us from the rest of the collaborative, or in other words, a site we staff. So just sort of trying to show, piggybacking off the other data from 2021 to 21-22, a consistent movement in our sites either toward or into the green. Questions?
We have a whole table of people to answer questions.
I have a quick question, if that's all right. Get started, hopefully. So, yeah, sorry, can I go?
No, you go.
Okay. I'm curious, you guys staff a variety of different types of hospitals and different volumes and whatnot, and if you've had any particular pushback from the smaller sites in receiving this information, have they been as receptive to the education and information that you guys are sharing with them, or how has that gone? I'm particularly just curious, because a lot of our sites have smaller piece volumes. I'm curious to hear how your engagement has been with those smaller sites that you staff.
So I'll take a stab at it, but anyone can jump in from that. So I don't really see the friction. I think when you start talking about what's best for them today is, in this case, the same thing that's best for the PEDS patients in 20 years. So sort of I care about your kid today, but I care about them 30 years from now too. And we're not doing, it's not like an attempt at a money grab or something like that. It's drilling down, how do we deliver the best quality care? And I think under that sort of umbrella, I just haven't seen resistance. I think, like it's been mentioned many times, the really small denominator makes it challenging. So when you have a month with 3 kids and you scan one of those 3, that's hard and probably not fixable, but I haven't seen, unless someone else is.
I had a question. I think I can do without the microphone. I'm just like beaming, as I was pointing out before, but is there, what in your experience with those non-children's portion of your network, is there something that stands out as more weighty in terms of its impact, or that you get more engagement from? One of, you showed us several of the interventions and where they happen. Where do you think like a big bulk of that comes from? Just because if somebody's looking at this saying, which of this menu could I pick for my site because it kind of looks like yours? What do you think?
I would say, I mean, it's difficult to pick one, but I think looking at the layers, because the same information isn't gone over once, it's gone over at a medical director's meeting and sort of partially disseminated to their pod, and then again at that same pod meeting. So the layers of the repetition, I guess. I don't know if I could focus on one. I'll say from like a content standpoint, the thing that I think helped was, again, instead of focusing on, okay, what makes you intermediate risk, it's within that intermediate risk group. And there's 2 or 3 papers since then that focus on the same thing. And then if you end up as an intermediate risk patient, what is your actual risk? So getting away from documenting, you know, mom really wanted this. We can drill down to the chart level, but also just on a broad-based level, like take a look at what your risk is if you end up in this category. That seemed to make a big difference. And I think we looked briefly at the pocket cards, if that answered your question.
Yeah, so my question. I always have questions. So I'm an extractor, and only thing I spend 3 plus weeks extracting, and then I have to meet 1 week maybe to try to pull all the full data and do all the reports and do all that. And I am just salivating thinking about doing individual clinician reports. I don't even know how you guys are looking at it.
I think we can take a stab at that. I think one of the things that we really benefit from is having, 1, a large group, and then 2, I think having our CMO, our clinical champion, really dedicated to supporting QI initiatives. So not only do our abstractors have protected time for quality intensive work, Chris and I also have a lot of time for that, and then also our medical directors, our clinical champions. I think everybody kind of contributes to the overall work, I think, to really give us some extra bandwidth. I think you can manage.
So another thing too, within the abstractor team, we have dedicated time to that QI work, and I think Terry especially has done a great job preparing these work group meetings. I think that's another critical piece, is getting everybody on board and working towards that same goal. And our work group meeting, it takes probably around a month of intentional dedicated time. We don't necessarily spend 10 hours during 1 week to get it. We like he and I meet probably over a 4 to 5 week time period. It's a week to make sure that, hey, we're pulling the right data. Is this prepped the right way? Does it look, is it telling the right story? Any questions that the physicians might have, we're trying to anticipate all that and then have that ready product for the work group meeting as well, has really helped make it impactful and have a really big buy-in because we get positive feedback in that we are prepared with the data that we have at that meeting too. So that's another critical piece to help make that successful if you guys take this on.